Assalamu alaikum. Good morning, everybody. Really want to thank the organizing and scientific committee for their kind invitation. And also I am so happy really with you. Today I want to talk about a very important subject. At the same time, there is some controversial point in the management of this disease. This is the agenda. We'll talk about it briefly. 2 case study, definition, causes, diagnosis, and the consequence of a clinical thyroid disorder and the guidelines regarding the management. So regarding subclinical hyperthyroidism, this case scenario, 65-year-old, a symptomatic woman. She has vast medical history of atrial fibrillation and beta blocker and oral warfarin. An examination, she has a nodular thyroid, TSH 0.095, free T4 is 1.3, and free T3. So basically this case has atrial fibrillation, nodular thyroid, and TSH is suppressed. I think this is a presentation 20 minutes, isn't it? Is it 20 or 15 minutes? Okay. So this is the case again. If come for us, what we'll do? Really, usually in a symptomatic or in subclinical thyroid disorder, we repeat the thyroid function test 3 months later on. But already this patient had nodular goiter. So probably I don't repeat the test, already the patient has nodular goiter. So again, showed subclinical hyperthyroidism in patient with atrial fibrillation. So what's the next investigation? Ultrasound thyroid, because already the patient has nodular thyroid in examination, and we'll do iodine scan or technetium. In our hospital, we have technetium 99 thyroid scan, showed slightly elevated uptake with batch distribution. So batch distribution usually in a tracer of iodine 123 or iodine 131 indicate nodular goiter or nodular toxic goiter. If homogeneous, usually indicate a Graves' disease. And maybe the uptake is normal. Even the uptake could be normal in patient with subclinical hyperthyroidism. So what you do for this patient? This patient has subclinical hyperthyroidism, multinodular toxic goiter. The treatment is radioactive iodine. Some patients, you can start an antithyroid medication like carbimazole or methimazole, but this is not definitive treatment, not like Graves' disease. In Graves' disease, if you start antithyroid medication, there is a chance of remission about 50 to 60%. But in nodular goiter, there is no remission with antithyroid medication. You can control the symptom, but no remission. So what's subclinical thyrotoxicosis is biochemical state of low TSH with normal T3 and T4. There is variable prevalence from 0.7 to 12, more common in women, more common in elderly, especially in iodine deficient area, and the commonest cause, as you know, is the treatment with thyroxine. Very important to rule out other causes before you diagnose subclinical hyperthyroidism, like for example, central hypothyroidism. The difference in central free T4 and T3 either low or in the lower side of the assay. In subclinical thyrotoxicosis, TSH is suppressed, but usually free T4 and T3 either in the middle range or in the higher range of the normal assay. Very important to rule out non-thyroid illness or physiological. Pregnancy is physiological. Hyperemesis gravidarum. Some people elderly, they have actually subclinical hyperthyroidism. Drugs like steroid, okay, especially connective tissue disease, patient in the ICU on dopamine, all this can affect thyroid function test. The causes of subclinical thyrotoxicosis is the same the causes of clinical thyrotoxicosis. Autonomous thyroid function, probably the most common in subclinical hyperthyroidism, Graves' disease, thyroiditis or recover of any form of thyrotoxicosis. So the same cause is actually the same of a clinical hyperthyroidism. So what's the workup? Repeat TSH after 2 to 3 months. Some patients, they recover 30 to 50%. Unlikely to recover if there is multinuclear toxic goiter or toxic adenoma. ECG if suspect AF, checks X-ray if suspect cardiomegaly. Usually in these cases we do thyroid scan to look for the uptake, and we do ultrasound thyroid if there is a clinical nodule, and DEXA scan in postmenopausal women. Some patient you have idiopathic subclinical hyperthyroidism. This case is most likely the reason is Graves' disease. So sometimes in subclinical hyperthyroidism, anti-TSH receptor antibodies like thyroid stimulating immunoglobulin will help us in the diagnosis. This is the effect. There is increased risk of a fracture in women with subclinical hyperthyroidism, especially if TSH less than 0.1. Also, there is increased risk of atrial fibrillation, and this is related to the TSH level. The lower the TSH level, the more risk of atrial fibrillation. In meta-analysis of 52 participants with subclinical hyperthyroidism from different studies showed there is increased risk of total mortality by 24%, especially in elderly above the age of 65 and TSH less than 0.1. So how you treat? If the patient more than 65 years of age, okay, you can see the, okay. If more than 65 or postmenopausal woman with osteoporosis, or the patient has atrial fibrillation, this is indication for treatment, especially if TSH less than 0.1. If TSH from 0.1 to 0.5, this is considered treatment, this is optional, but any of these 5 with TSH less than 0.1, you treat. If the patient is symptomatic and less than 65 years and asymptomatic, and TSH from 0.1 to 0.5, there is no need for treatment, and you can observe them every 6 months by thyroid function test. If TSH less than 0.1 and asymptomatic, you may consider the treatment. In a pregnancy, of course, there is no indication to treat subclinical hyperthyroidism. The second case, 72-year female, asymptomatic, no history of cardiovascular disease, no family history of thyroid disease, no goiter examination, total cholesterol 200, routine screening showed TSH 8, free T4 is normal, and repeated TSH the same. So basically, this is a symptomatic elderly patient with TSH is 8. So this is going with subclinical hypothyroidism. Really, in subclinical hypothyroidism, I do antithyroid peroxidase antibodies to know is it Hashimoto's thyroiditis or not. So should we treat this patient or not? Okay, elderly, yes or no? Who is yes, who is with no? TSH 8 and asymptomatic. So who suggests will treat or not treat? Huh? No treatment. Excellent. Treatment. Who will treat? Okay. So now, this is the European Thyroid Association guidelines in 2012. If at the age of more than 70 and TSH less than 10, just observe the patient. If more than 10, you may treat if there is symptoms or there is high cardiovascular risk, like for example, patient with heart failure, with ischemic heart disease, okay, you treat this patient. The American Thyroid Association actually is different. They treat less than 10 if they have symptoms of hypothyroidism, if they have antithyroid peroxidase antibodies positive indicated Hashimoto's thyroiditis, if there is goiter, if there is ischemic heart disease or AF, if there is heart failure. And they treat all the patients of more than 10. We can see with age TSH has increased. So above the age of 80, more than 40% of the patients, they have TSH more than 4.5. So this is maybe protective for them. So if you didn't treat elderly, observe the TSH every 6 months. If increase more than 10, maybe you will treat this patient. So this is study done in thyroid hormone therapy for older patients, RCT trial. They include 730 patients, age 74, baseline TSH from 4.6 to 20. They started thyroxine 25. Primary endpoint was hypothyroid symptoms and the quality of life. So the result, there is no improvement in hypothyroid symptom score or tiredness. So no benefit of thyroxine treatment in older patients with subclinical hypothyroidism. So this is the definition again, subclinical hypothyroidism. Overt hypothyroidism, usually TSH more than 10 and low free T4. Subclinical hypothyroidism, TSH usually less than 10 and normal free T4 and T3. Prevalence from 4 to 10%. Sometimes referred as mild or early hypothyroidism. Prevalence increase with age, of course, they more in elderly. So there are two grades. One mild from 4 to 10 TSH and more severe, more than 10. And thyroid peroxidase antibodies is positive from 60 to 80% of the cases of subclinical hypothyroidism. The TSH assay depends on the lab, but usually the upper limit of normal from 4 to 4.5. In elderly, around 6 to 7. In a pregnancy, TSH level from 0.3 to 4. We know that in a pregnancy, especially the end of the first trimester, TSH may be suppressed. And this does not need any treatment actually, because of the effect of beta HCG. The same etiology of subclinical is the same like clinical hypothyroidism. Hashimoto's thyroiditis is the commonest. In some countries, iodine deficiency, drugs, amiodarone, radiation, or thyroxine. Very important to rule out other causes of increased TSH and they don't have thyroid disease. For example, following thyroiditis, lab error, sometimes heterophile antibodies. Actually, I have one patient, TSH is around 260 and the free T4, T3 was normal and asymptomatic, and turned to have anti-heterophile antibodies, anti-mouse antibodies. So we sent for assay outside and there is interfering antibodies. Very important patient in the hospital admitted and discharged, and you do thyroid function test, maybe you will find subclinical hypothyroidism. So very important to repeat TSH after 3 months, because this is long-term treatment, except in a pregnancy. The only exception for treatment is a pregnancy. Impaired renal function, antidopaminergic drugs, patient with irritable bowel syndrome, adrenal insufficiency. Very rarely you can have high TSH alone, and usually this is a patient sick. TSH secreting pituitary tumors, okay, they can have high TSH and pituitary resistance, and all these three are really rare. Very important to repeat the test. Don't hurry to treat this patient, except in a pregnancy, because many patients, up to 1/3 of the patient, they will recover thyroid. Because many patients in a clinical practice, actually, we stop antithyroid medication, because this patient probably, they have subclinical thyroid disorder. How I know that the patient have subclinical? If the thyroxine dose, if the patient come to the clinic and thyroxine dose less than 1.2 microgram per kg, I should suspect that the patient has already subclinical hypothyroidism, and I can stop the treatment and observe the patient. We'll do antithyroid peroxidase in every. So this is studying up to 46% of the patient with subclinical hypothyroidism who have TSH less than 7, TSH normalized within 2 years. So you see most of them. Consequence, you can have progression to overt, high serum cholesterol, cardiovascular morbidity, maternal and fetal consequence in pregnancy, and non-alcoholic fatty liver. Okay, so if the antithyroid peroxidase antibody is positive, a progression 4% per year. If negative, 2 to 3. So more, if you have antibody positive, the progression is more. If TSH more than 10, there is significant increase in cardiovascular mortality. If less than 7, not associated with increased cardiovascular mortality. Sorry. Symptoms. So what's the effect of the treatment in the symptom? There is no significant effect in equality. So if the patient doesn't have symptom or mild symptom, there is less effect in the symptom. What's about effect in lipid? There is modest reduction of LDL. There is no effect, okay, in HDL or triglyceride. What's about the effect of weight? Subclinical hypothyroidism is more common of obese. So in obese patient, most likely the obesity is the cause of high TSH rather than subclinical hypothyroidism. So treatment of subclinical hypothyroidism will reduce the weight by almost 0.5 kilogram. So very important in obese patient to reduce the weight, and usually the TSH will come down. What effect in the cardiovascular system? If you can see here, if the patient is less than 70 years, the hazard ratio is 40. So thyroxine probably, this is observation study, we reduce cardiovascular event by 40%. If more than 70, there is no effect. Very important to avoid TSH below 0.1 or more than 20, because both exogenous hyperthyroidism and exogenous hypothyroidism were associated with increased risk of cardiovascular mortality. This finding emphasizes the importance of maintaining euthyroidism to decrease cardiovascular risk and death. So try to avoid TSH less than 0.1 or TSH more than 20, because in this observational studies may increase. Okay, so regarding subclinical hyperthyroidism, we treat if TSH less than 0.1, we treat if the age more than 65, or there is atrial fibrillation or osteoporosis. The other patients, we can observe them in subclinical hyperthyroidism. If the age less than 65 and the symptomatic, we observe them. Most of the cases of idiopathic subclinical hyperthyroidism is due to Graves' disease, and you can do anti-TSH receptor antibodies. Regarding hypothyroidism or subclinical hypothyroidism, you treat if TSH more than 10, if the patient symptomatic, if the patient has goiter or antithyroid peroxidase antibodies. If the age above 70, don't treat this patient. You observe them. If they develop overt hypothyroidism, you can treat them. This is a replacement, 1 microgram per kg, and you keep TSH from 0.5 to 2.5. Above the age of 70, you keep TSH from 3 to 6. Thank you very much.